Sounds great. Dr. Keller, you mentioned the importance of access to evidence-based services for those with severe mental illness. As we both know, the coordinated specialty care is an evidence-based suite of services for those with first episode psychosis. And yet, and it was part of a mental health reform bill that Chris Murphy and I put together in 2016 to expand access. And yet I find out that this access is actually quite limited, even though NIH verifies that it's just what we should be doing. Um, so I've learned in general, Medicaid will cover parts of the continuum, but not a coordinated specialty care comprehensive approach. That every state receives SAMHSA community health block grant dollars, which are required set aside for first episode psychosis that could be braided into the Medicaid dollar to provide the comprehensive access. So I guess my question for you as being on the front line, why has it been so difficult to implement the coordinated specialty care for states and providers? I guess I'll start with that.
Well, thank you, Senator Cassidy, for bringing attention to that. And I want to commend SAMHSA for the set aside for first episode psychosis care. In Texas, we have used that to dramatically expand our capacity. The problem is that it's primarily available to people who are either uninsured, who are served through the block grant, or some people with Medicaid. And Medicaid makes it difficult to pay for it because of the fragmented funding approach that you talked about. So I think the reforms you talked about and the need for Medicaid to have value-based purchasing arrangements and bundled payments to be able to pay for that would make it easier to expand that access. But I think it also needs to be expanded to commercial insurance. This is why parity enforcement is essential, because the onset of schizophrenia, the onset of severe bipolar disorder are not limited to people without insurance or who are in poverty. People with commercial insurance deserve the same access. And I will tell you today, we have a two-tiered system in the state of Texas for people with coordinated specialty care. We have excellent access for people who do not have insurance, and we have almost no access for people who do have insurance unless they want to pay out of pocket.
But let me ask you one that's very troubling. But for those who don't have insurance, what I've heard and what I think I heard you say is that Medicaid and SAMHSA don't really work well together. By the way, you can thank Congress for making SAMHSA do that set aside. But that said, they don't work well together. Yet then you said that they actually have excellent access. So square that for me.
Yeah, absolutely. So the work has been done on the ground in Texas by Texas providers to basically take the set aside, which thank you to Congress for doing that, because that did make it easier for our providers to stand that up. And then they have to do the mind-numbing work at the clinic to do that. And not every clinic is able to do that. So the access for uninsured people through the block grant is excellent. The access through Medicaid is spotty. And really, I do believe you are correct, Senator, that better coordination, and I believe the current SAMHSA Assistant Secretary is working on that. I think for CMS, it needs to be a priority. CMS has so many things going on. If they could prioritize this for expedited sort of work and work on these bundled payment arrangements, that would be wonderful.
Okay, Mr. Williams, thank you very much for that. You spoke about the mental health of people who are dually eligible for Medicare and Medicaid, and that nearly 1/3 of duals have a serious mental illness such as schizophrenia, bipolar, or severe major depressive disorder, a rate 3 times higher than that of the non-dual patient. But you know, dual eligibles have worse outcomes than those who are not dually eligible. And my office has been looking at this, and we have found that if you take a state which doesn't have a dual eligible population compared to one that does, and you take same type of patient in both states, the academic literature suggests that where they don't have two forms of coverage, they actually do better. If you will, giving them the second form of coverage, dividing the care between the incentives for the care, actually ends up making things worse. So any thoughts about that? Because the duals do terrible. And is it part of the problem, the fact that they are duals as opposed to only one payor?
Senator, thank you for that question. The needs of the duals population are complex. Administrative barriers disproportionately deter poor and marginalized communities and individuals from receiving healthcare services. Low-income people who have to work long hours or have limited health literacy or...
Well, Mr. Williams, I'm almost out of time, so let me cut to the chase. Is it possible that actually making them a dual giving them both Medicaid and Medicare coverage, although you do it because you want to help, may be part of the problem?
Our healthcare system is complex. We need individuals like patient navigators to really help dual eligible Medicare beneficiaries access services. And back to my 3 points that I mentioned in my remarks. Mental health services can be integrated at the site of primary care. So engaging in that primary care office and getting people access to the services and navigating those administrative requirements is important. Second, having qualified providers like peers, community health workers, and others that can be resources to individuals to help them navigate the complexity. And then finally, the sharing of technology and information. Having data at your fingertips as a provider and as a patient are ways that you can navigate those complexities associated with being a dual eligible. And we see promising things with special needs plans, which have been customized to meet the behavioral health needs of many individuals.
I thank you, and I yield, Mr. Chairman.
Thank you, Senator Cassidy.